My project was about genomic drivers of renal cell carcinoma and their implication for immunotherapy. So our goal was to determine what are the genomic abnormalities that makes the tumor to metastasize to brain. In other words, what makes the tumor to have a tropism towards a development and adapting to the brain microenvironment. And beyond that, how we can utilize it in combination with immune checkpoint inhibitors. We actually presented this study findings at AACR meeting last year, and we basically used this funding to perform the single nucleus RNA sequencing from the patient samples that were collected from 3 different institutions at that time. And it helped us to understand the tumor microenvironment of the kidney cancer brain metastasis in comparison to the matched extracranial and primary tumors. And this data helped us to identify novel adaptation mechanisms of the tumor cells in the brain microenvironment that help them to adapt to the different environment of brain, which is due to the blood-brain barrier and the nutrients in the CSF being different from the peripheral blood. And moreover, this helped us to define new targets. Let me dive deeper a little bit on the findings of the study. One unique thing we learned from this analysis was that brain is different because of having a lot of neuronal cells in the microenvironment, and neuronal cells interaction with the immune component, stromal cells and tumor cells is making the tumor to behave different compared to all other sites of the disease. And we hypothesized that this is the reason why immune checkpoint inhibitors has limited efficacy in brain metastasis, and how we can tackle this problem by targeting different cellular components of the brain microenvironment. So what we learned there is the FGFR signaling is important in the neuronal maintenance of the brain microenvironment. Moreover, neuronal cells communicate with the kidney cancer tumor cells using the FGFR signaling as well. And fortunately, from our current armamentarium of the renal cell carcinoma, we were able to identify a tyrosine kinase inhibitor, lenvatinib, that is already known to have an ability to inhibit the FGFR, but this has not been leveraged in this setting with this approach and hypothesis. So this study led to an investigator-initiated clinical trial testing pembrolizumab plus lenvatinib, which is going to be one of the few multi-center kidney cancer brain metastasis studies that is going to be opening at Ohio State University, MD Anderson, and few other DoD kidney cancer research consortium centers. Actually, this question takes me back to my very early stage in career. After finishing the medical school, I landed to a laboratory where I worked with Dr. Cheryl Walker and Ruhi Dere. At that point, I was having a deep dive on the VHL and related signaling mechanisms. Later in my career, I worked with Dr. Eric Jonasz, where I got involved in more clinical trial and clinical questions. And it was actually on my second month of the clinical training, my first patient encounter, I remember it was Dr. Nizar Tanir's clinic, was about a patient who had excellent response to immunotherapy in all other sites of the disease, and however developed new brain metastasis. And this made us to ask the question that how we can, this is a pattern that is going to happen in many other patients in the stage of the immunotherapy, and how we will be able to answer this question. So from the clinical observation, from that patient interaction, we took it to the next stage with Dr. Jonas and come up with this proposal where we now have a better idea than before what makes to the kidney cancer brain metastasis to be able to survive in the brain microenvironment, why immune checkpoint inhibitors have better efficacy results in other sites of the disease compared to here. And luckily, I can say that we were able to translate these findings into a clinical trial back to the patients where now we are able to about to open this study testing this regimen in patients who has active brain metastasis. In a similar context, what I can say is this is also part of our family discussions that we commonly discuss this in a dinner table with my wife, who is also a melanoma brain metastasis specialist. And we see that there's really a burning unmet need for the patients with brain metastasis, that we need to deconvolute the tumor microenvironment, find better targets, and also expand the clinical trial options for these patients, where joining forces, collaborating with all other folks in this space that is helping to understand the metastasis tropism, I think will help us to get better options for patients with kidney cancer and brain metastasis. In terms of the patient's perspective as of today, I would say that every patient should advocate for them to have at least one MRI brain imaging as part of their baseline screening. So this way they will start the treatment with the knowledge that whether they have a brain metastasis or they don't have, because we already have study reports from other groups showing that there is incidental brain metastasis finding at the time of the study enrollment, where this is most of the time is overlooked and assumed that there's no disease. So it will be better to start with that information and then continue monitoring from time to time. And now this is actually already integrated to NCCN guidelines, so it should be covered by insurance. I am not sure how much this is commonly practiced across the nation, but I think the patients should advocate for starting with baseline information and taking the information from there. The next thing, if someone has a brain metastasis, I think the key word there is multidisciplinary care. Almost on daily, weekly basis, I communicate with my colleagues with neurosurgery or radiation oncology, where we discuss the patient that whether surgery or stereotactic radiation versus systemic treatment is the wise option to move forward. If someone has one lesion, the answer is different. If someone has many lesions, depending on the site and size or the symptomatic status of the patient, the options are different. And I think the key point there is making sure that the physicians who are taking care of that patient is in active communication. I always describe this brain metastasis as a ticking bomb inside the brain, where you would like to have not only one person to cut that wire from a movie scene, that is it red or blue. You want to have a team of physicians with different skill sets to come up together and decide how they should tackle this problem, and then later prevent the new brain metastasis formation. Yes, I'm very thankful for KCA and all supporters for this funding opportunity. This has actually built the foundation of my current laboratory, which is at Pelotonia Institute for Immuno-Oncology at James Cancer Hospital, Ohio State University, where now we have a big team of trainees and scientists with a focus of translational bioinformatics, which is deeply diving into the brain architecture and studying every cell and trying to identify what are the targets that we should go after: T cell, myeloid cell, neuronal cell, stromal cell versus the tumor cell, that hopefully this will help us to define better targets for the future options after this study to outline more options for the patients. I would highly recommend the young investigators to be deeply involved at early stage in their careers with the patient advocacy groups, organizations. And why it's important? Because these organizations are advocating for patients who we are caring on the other side of the table for their challenging disease that they face. So to be able to know what patients need, this is another channel of information that we need to really keep the pulse of the events, and what do the patients want to know about their disease, what they don't want to know about their disease, what options do they have, where they're struggling with organization of their, how to address the needs of their disease versus they are only looking for the biological and other mechanism and how to address it. So it helped me to learn a lot in this process, to recognize that the patient advocacy organizations are actually a vital part of both physician and scientist career, and it's better to be involved earlier in their career, where you will have more information about at every layer how to help our patients from different aspects.